Good afternoon, and thank you for giving me this opportunity to talk about the management of complex calcified coronary lesions. My name is Dr. Mehmood, sir. So these are my disclosures. So calcified coronary artery lesions are important. Significant calcification coronary arteries is encountered in about 1 out of 10, 7 to 10% of the patients. Calcified lesions are difficult to cross deliver devices. There is higher failure rate due to dilatation, difficulty with conventional balloon angioplasty, higher risk of complication, especially coronary perforation, stent under expansion, future risk of thrombosis and restenosis. So coronary calcification can be readily identified by most of the imaging modalities, including the CT coronary angiogram, where the calcium scoring can also be performed, which is usually the initial investigation for majority of the patient, and can also help in preparation of the future intervention and management. Coronary angiography shows tram-track appearance, and it can help measure the length, severity, and tortuosity of the calcified lesion. IVUS and OCT are both very helpful to measure the arc length and the nature of the calcification in the coronary arteries. The additional benefit of OCT is that you can also measure the thickness of the calcification. So various scoring systems have been devised to determine that whether plaque modification devices are required, and one of them is ROTA score. Score more than 3 is proposed to require plaque modification, and it's based on whether the lesion is bifurcation, the tortuosity of the lesion, severity of the calcification, length of the calcification. Similarly, scoring system through IVUS and OCT are also devised based on the length and the arc of the calcification in IVUS, and additionally the thickness with the OCT. Coronary calcification do affect the outcome of patient, as the pooled analysis of the Horizon AMI and equity trial showed significantly increased mass with severe calcification. Calcified nodules can be difficult to treat. However, IVL and orbital atherectomy may be helpful in this case. Various techniques which are used for this purpose include rotational atherectomy, orbital atherectomy, laser, IVL, and this slide shows their ease of use, the training required, and deliverability, and the cost, etc. Various algorithms have been devised to decide when and how to use these devices, which are very helpful in decision making. However, a simple rule is that if you have a calcified lesion which is balloon uncrossable, then the choice you have is to go for rotational atherectomy or orbital atherectomy. And if the lesion is balloon crossable, then you have a choice of IVL, cutting balloon OPN. And remember, OPN will increase the chances of coronary perforation, especially in eccentric calcified lesions. Imaging guiding percutaneous coronary intervention has been shown to improve the outcome, both the IVUS and OCT. Intracoronary imaging is useful to determine the plaque burden, morphology, arc of calcification, length of calcification, thickness of calcification, vessel size, and it helps to define the strategy. Rotational atherectomy, there's a European expert consensus rotational atherectomy document which defines the various parameters, the guide wire use, the burr size, burr motion, and the burr speed. The rotational atherectomy still carries high risk of complication despite experience, so it should be only performed by experienced operator after proper training. The evidence for the plaque modification is still not very supportive. The Rotaxis trial, Repair Calc trial, and all other trials showed no benefit over the conventional angioplasty. The comparative study of rotational atherectomy and orbital atherectomy showed that orbital atherectomy might be helpful in a deeper tissue modification and improved stent expansion. Intravascular lithotripsy, so DISRUPT coronary artery trial showed the safety and effectiveness of the IVL. However, a small study showed no significant benefit in terms of MACE by using IVL in comparison to the conventional balloon angioplasty. AHA guidelines and the ESC guidelines do recommend the use of rotational atherectomy and the other calcium modification devices, including IVL, in the heavily fibrotic lesions and calcified lesions. The plaque modification trend has changed significantly since the introduction of IVL, and we can see from the slides that the IVL take-up was quite quick and significant. So I would like to just talk about two of my recent cases. So this was a 71-year-old gentleman, smoker, diabetic, and hypertensive. He is known to have triple vessel disease, and he was advised to have a CABG a year ago, which he declined. He also had failed attempt of PCI elsewhere, admitted to our center with NSTEMI. His echo showed a normal LV systolic function. This is his coronary angiogram, so you can appreciate the calcification in the proximal LAD, as well as the lesions in the circumflex. I'll just go through the pictures one by one. And this was his right coronary artery, which was also heavily calcified. So I did pressure-wire study of the LAD, and the main purpose of the pressure wire was to analyze the proximal LAD, that whether there's need for stenting there as well or not. So the pullback showed that normalization of the IFR in the proximal LAD. The option of bypass operation was offered to the patient. Patient declined. Patient was discussed in MDT, so decided to proceed to PCI. Rotational atherectomy of the LAD was performed. So right radial artery access was used, 6-French sheath, and EBU guide 1.5 burr was used. So the LAD was treated with rotabur. And then further pre-dilatation was performed with angiosculp 3 by 15 millimeter balloon, which well expanded after a few dilatation across the vessel. Intentionally, I haven't shown all the dilatation, but just for proof of point, I've showed few dilatation there. And then I delivered 2 overlapping 3 times 38 and 3.5 by 12 millimeter Science Skypoint stent at 16 atmospheric pressure. And then I post-dilated the stents with NC balloon. And this was the final result. So then I brought the patient back for stage PCI to circumflex and right coronary artery, which was more challenging, especially the right coronary artery, which you will see in a few minutes. Check angiogram of the LAD showed good result there. And PCI to LCX was performed. The lesion in the LCX was pre-dilated with 2.5, 15 non-compliant balloon initially, and then with scoring balloon. And then I delivered 3.5 times 18 millimeter resolute onyx stent and post-dilated the proximal stent with 4 times 8 NC. And this was the final result on the circumflex. PCI to RCA, so this was the most difficult one. This was the strategy, so used the right radial artery, axis, and 6-French sheath. I did this immediately after the circumflex. GR4 guiding catheter was used, rotawire floppy was used, 1.5 burr was used. So across the lesion, patient developed bradycardia. I gave him atropine 0.5 milligram IV, and then we carried on with further rotational atherectomy. I exchanged the rotawire with BMW. However, before delivering the stent, I tried to pre-dilate the lesion further with the 3 times 15 millimeter angiosculp balloon. Despite multiple attempts, I couldn't deliver that. So I decided to pre-dilate further with 2.5, 15 semi-compliant balloon. And multiple areas of non-dilatations were noted. After that, I tried to pre-dilate again with 3 times 10 NC. In multiple areas, again, I noted non-dilatation. tried to cross the lesion again with endoskop scoring balloon. However, it was difficult to cross, so at this stage I decided to increase the support by changing to Grand Slam wire and used guide liner and decided to go for IVL. So as discussed, the IVL was delivered with the help of the guide liner, and the whole calcified area was treated with the same balloon. So you can see some improvement there. And then I performed further pre-dilatation before the stent, just to make sure, with 3.5, 15 NC balloon, which was satisfactory. And then I deployed two overlapping 3.5 times 848 and 3.5 18 millimeter Zeiss SkyPoint stent and post-dilated it with a 4.0 NC balloon. And this was the final result on the right coronary artery. So the second case was a patient I treated calcified lesion with cutting balloon. So 67-year-old gentleman, strong family history of premature coronary artery disease, present with NSTEMI, normal echocardiogram. This was his coronary angiogram, and his presentation was with NSTEMI. I noticed you might be able to see a shadow of the branch of the OM, which was the most probable culprit lesion at that time. However, I decided not to go ahead and open it because the patient had symptoms for more than 12 hours. I'll show you the LAD, so significant disease in the LAD. Multiple bifurcations, and the RCA was small. So, as I mentioned, I left the branch of OM alone without opening. Sorry. Can you go back to the slides?
Okay. Give him 1 minute, please. If you can kindly finish it in 1 minute, we highly appreciate that.
Okay. So MDT discussion was again made, recommended to go for bypass operation. Patient declined, patient wanted to go for PCI, therefore treated the LAD with cutting balloon. Pre-dilatation, initially I started off with semi-compliant balloon 2.515. However, they failed to dilate, so IVUS was performed, which showed significant calcification throughout the LAD. And then I treated the lesion with Wolverine 2.75 times 10 millimeter cutting balloon. Repeat IVUS performed to make sure the calcification is correct. Further pre-dilatation performed with 3 times 15 angioscalp balloon throughout the mid and proximal LAD. So it's going.
Just last.
Yeah,
Give him 30 seconds, please.
Okay. So I'll show the final result after the treatment. The stent was deployed, treated, and casing balloon inflation performed of the. So this was the result in the LAD. There was small dissection in the D2 ostium. However, I left it alone and started patient on tirofiban. This was the kissing balloon of the proximal small diagonal, and the IVUS performed. So in conclusion, as we all know that coronary calcification is more common in people with increasing age, diabetes, smoking, CKD. Step-by-step approach and change in strategy are required to achieve best results. A dilatation with scoring balloon after rotational atherectomy, IVL, is always helpful before stent deployment, and be prepared to use combination of calcium modification techniques in same vessel. Appropriate technique using rotational atherectomy, orbital atherectomy, and IVL always help. The IVL has changed the landscape and is being used quite frequently nowadays.
Thank you.